anti-CCP. And another thing is that other prognostic importance is that if anti-CCP value is very high, like 120 or 130 or 230, we will get that type of patients also. If that value is very high, then you can assume that the erosion of the bone tissue is more. So there is a relationship between the value, the titer value, and the erosion of the bone. So we can predict the complication also. So it is a very beautiful test in the diagnosis of diagnosis, even and the management of this rheumatoid arthritis. And another thing is anti-stabilize, ASO titer, as everybody knows, because it is a test which is in relation to, or a test which helps to diagnose the rheumatic fever. Is traditionally it is doing, but in that test also some false positive test will be occurring. For example, many patients with some other system means infections also get positive that ASO. That doesn't mean that the patient is having rheumatic fever. So always the test report should be considered on clinical ground only. For example, if you are getting the Jones criteria for diagnosis of rheumatic fever, major and minor, then with this ASO titer, then you can positive, then you can say that this test positivity is in favor of this rheumatic fever. Otherwise, if the patient is having no criterion and no that criteria is not fulfilled at all, but the ASO is positive, then we can ask the patient that this is not rheumatic fever. It is a test negative positive, false positive result. You don't worry. In that way, you can interpret and you can clarify. That is about the ASO titer. And comes the most important test, anti-nuclear antibodies. Anti-nuclear antibodies, one thing, the values, the normal values, either you can go in the you can go and refer in the test books, or you will get the in the lab that report itself. Why? Because the method and the kits they are using will be different, and the reporting values will be also different mostly. So that is very simple. You can get it from the that report itself. So anti-nuclear antibodies. Anti-nuclear antibodies are a group of antibodies which help us to diagnose the connective tissue disorder, collagen disorders, etc. For example, if a patient comes to you with a painful joint and butterfly rashes, or fever, or mild fever, or some skin rashes, or some that excessive skin fall, so the hair fall, then you can suspect clinically, you can suspect that the patient may have that NCTD, or multiple connective tissue disorder, or an SLE, and then we can write an ANA test for supporting the diagnosis. And in the fragments of the ANA we can also write ANA profile also. In ANA profile, double stranded DNA or antides DNA is highly suggestive of this that SLE, and some other categories are also there, like the Sjogren syndrome. Sjogren syndrome also can be diagnosed from the anti-nuclear antibody that profile. And another most important that rheumatological condition or connective tissue condition is sclerosis or systemic sclerosis. Systemic sclerosis also can be diagnosed from the profile of anti-nuclear antibody. So these are the three conditions which can be diagnosed very clearly on the basis of this positiveness of the anti-nuclear antibody positiveness and the categories. So SLE, that sclerosis or scleroderma or systemic sclerosis, and Sjogren syndrome. These are the conditions it can be diagnosed as. diagnosed with the help of this anti-nuclear antibodies. For example, if a patient comes to you, is having some vague joint pain or body pain, fatigue, and the eye pain or redness in the eye or dryness of the eye or dryness of the mouth, then we can suspect a Sjogren syndrome. Then, to clarify, to confirm the diagnosis, we can give a profile on the anti-nuclear antibody. Mm. So with that profile, if the positiveness is obtained, we can confirmly diagnose that the patient is having Sjogren syndrome. So it's a very beautiful test which can be applied. It is not too costly also. And then that serum uric acid, everybody knows that serum uric acid is a common test which comes under renal function test. But we are using that for that diagnosing the hyperuricemia condition and for diagnosing the gouty arthritis conditions. But nowadays, more than the condition which people are seeking medical help very frequently is hyperuricemic condition. That presentation of the joint disease as gouty arthritis is very less when compared to uricemic condition. But uricemic condition, hyperuricemic condition is a common condition, and which is now the paper, the research is saying that it is having a relation with the cardiovascular health also. So hyperuricemic condition also have to be treated well. So you have to look into the serum uric acid level for identifying the hyper uricemia or uric acid that gouty arthritis or crystal arthritis. And then comes the HLA B27, not 1327, HLA B27. Uh, that HLA B27 status is very important in the diagnosis of that SSA or ankylosing spondylitis. Ankylosing spondylitis or seronegative spondyloarthropathy. Uh, so it's a genetically linked that factor in the lab findings, but that will be this HLA-B21 will be present in the patient who are having this ankylosing spondylitis. So if a male patient presented with a young male patient of 20 years presented you with continuous that back pain and hip pain, or with shoulder pain or neck pain, and gradually increasing with rest and relieving with movements, and it is continuous, then you can suspect a condition of this ankylosing spondylitis or SSA. And if the symptoms are very much clear and the criterion is very much clear, then there is no need of seeing the HLA-B27 status. Because clinically itself we can diagnose it as ankylosing spondylitis. And if we are very particular, we can go for the HLA-B27 status. Then reporting will be that HLA-B27 is detected or present in the sample. So it is suggestive of ankylosing spondylitis or seronegative spondyloarthropathy. Okay, this is about the musculoskeletal disorders, the investigations, and all. Say, now we can come to the GAT disorders. GAT. What are the investigations that commonly we can do in the gastrointestinal disorder? And investigations in relation to blood, examination in relation to feces, then ascitic fluid analysis, special test Helicobacter pylori. It is common. So, in investigation of gastrointestinal disorders, commonly um, the the hematological parameters also we can made use of regarding the HB and the TC, the DC, and all. That also that we can utilize, and and then other hepatobiliary pathology related investigations we'll discuss later. So I am not going into the that part, like liver function test. I am not telling. And then naturally, the next important thing is that examination of the fecal matter motion. So in that, we have to conduct a routine examination to identify the parasite or mucus or blood, occult blood. Blood is very important. Then OVA means if the patient is having some parasite infection, naturally the will be present like amoebiasis, then that closing stomach, that hookworm infection, and this worm infestation generally, amoebiasis, the second one, and if some in some conditions like ulcerative colitis and that Crohn's disease, there will be occult blood, and in so many other conditions also occult blood will be there. That we have to differentiate. So occult blood we have to see, the mucus we have to see, the reducing sugar we can see. So all these gives an idea regarding the large bowel of the means the last portion of the gastrointestinal tract, and so it is diagnostic, and that can be the diagnostic, the parameters can be having from the concerned portion of the that bowel disorder, inflammatory bowel diseases, and parasitological conditions, and we go through and you do uh, that motion test or stool test examination of stool. Then ascitic fluid analysis, that is that is not so easy to do in an Ayurvedic clinical setup, but that can be done, and the level of ascitic fluid will be differentiating the cause of etiology of that ascites, whether it is cryptogenic or malignancy or tuberculosis or any other infections are there, that can be identified from the ascitic fluid analysis. And one of the most important villain or means organism which causes continuous ulcerations in the in the stomach or in the GIT is Helicobacter pylori. So, if a patient comes to you with a continuous history of acidity, that painful abdomen, especially with gastritis or epigastritis, continuous epigastritis or gastritis, without response to any common that antacids or medicines, amlavita or sula, that line of elements, then definitely you have to go for a antibody test of Helicobacter pylori. If that Helicobacter pylori is there, then that will be an etiology. It's a major etiology for this type of that operations in the gastrointestinal tract. Then accordingly we can treat the health. So it is an important investigation, and these are the tests related with pancreatic disorders. Pancreatic disorders. In acute and chronic pancreatitis, naturally in acute pancreatitis there will be abdominal pain, and as you know, diarrhea. The patient will not be tolerating the fatty food or the milk or the milk products. So in acute and chronic pancreatitis, you have to, if you suspect pancreatitis, then you have to see the serum amylase and lipase. And serum lipase is very important. Why? Because with the inflammation, the lipase will be produced more, and the inflammation in the pancreatic cells, lipase will be produced more, and the level of lipase will be high. So that is very important. And actually, in Ayurveda, there is a very good the treatment methods are available for this acute and chronic pancreatitis. So in that suspicion, we can confirm the condition with we can confirm the diagnosis with the serum amylase and lipase, but you have to substantiate your diagnosis with other ultrasonogram and all. Why? Because we have to have some other differentials like malignancy of the pancreatic pancreas that we have to rule out, and so many other things we have to keep in differential diagnosis also, so that you have to read. And the most important thing in GIT disorder is cancer markers or tumor markers. So it is very important. If a patient comes to you with a pain abdomen, not responding to the first line therapies, then and even for the second line therapies, or on and off it is coming now that with the first line therapies it was okay, and again the patient recurrence was happened, and the general condition of the patient also, if it is deteriorating, like anemia is developed, fatigue is developed, the body weight is reduced, low grade fever was developed, then that general symptoms like anorexia, loss of appetite, everything is developed, then you have to go for tumor markers. And the first tumor marker is CEA, carcinoma embryonic antigen, that is specific to colon cancer. So that can be, we can write in the let's put that CEA marker, cancer marker for CEA, and that can be utilized for the diagnosis of colon cancer. Colorectal cancer is very common in our country now, so we can utilize the CEA the marker for the diagnosis of cancer. And then AFP. AFP is a very simple test to identify the hepatocellular carcinoma. If anybody in the middle age is having a very chronic alcohol history, or a that hepatitis, viral hepatitis history, then definitely you can do a and if the body weight is reducing, the other marker means enzymes are highly elevated, like that GGT and all is highly elevated, like 150, 2000, sorry, 250, like that elevated. And thrombocytes are very reduced. So many other findings also you got. Then you can write you can do a test of alpha beta protein. So it is highly specific to liver CA, hepatocellular carcinoma. And if it is elevated in a large level, then definitely that patient will have cancer of the liver. Then CA19, that is a marker of the pancreatic cancer. Very simple marker. Right? So, see the importance of, I will say, one politician is a very famous politician. He was almost apparently healthy and was good, kind of well for a medical checkup, routine medical checkup, not for a particular disease. Just he was at the 50s, and so he went for a medical checkup, and the doctor that as a part of screening, returned to look into the CA19 also. That Then that happened. Unfortunately, the reports came, the CA19 marker was highly elevated, and that asymptomatic patient had basically he had cancer pancreas. So then, see, this is the importance of this evaluation. At times, we cannot identify, or we will not get the symptoms. But we will be getting the symptom at an advanced stage. So the markers are very helpful in identifying the hidden diseases of the person. So that is very important. So markers can be placed. So the last one is PSA. PSA is not in relation to GET, it is in relation to genitourinary. But I put this here because of literally nature, because it is a marker also. So PSA is nothing but it is a marker of the prostatic CA. So PSA is very cheap, and it's a commonly doing test in the elderly. So prostatic uh, secretion assay, that's a very simple test. So PSA can be done in a patient with a suspected BPH, or in all patients with BPH. Every year we have to do PSA test. If it is increasing more than 5 or 6, then we have to carefully handle, and we have to explain to the patient that PSA is increasing. We have to look into the PSA every 6 months, and if it is responding to treatment, is okay. Or if it is above 20, means we have to go for other evaluations of prostatic CA like biopsy and all. So these are the markers of cancer that we can commonly practice. These are the common markers of the cancer. Uh, Uncommon, so many other evaluation that tests are there. It is not mentioned here. So these are the common markers which can be done by graduate medical what we can say graduate practitioners in every clinic or consultation facility, because all of these tests are available in almost all the laboratories. So it can be done very easily, and the cost is also not too much. Then, in what are the investigations to be done in liver disorders? See, in the liver disorders are a trust area which Ayurveda doctors are handling. So naturally, we should have an idea regarding the examination, the signs and symptoms of the liver diseases. Then, if the signs and symptoms are obtained, naturally we have to examine the liver. Then, after the examination, if you suspect some pathology in the liver, then you have to do an investigation of the to identify the liver disorder. There are uh, 2-3 groups of liver disorders. For example, infectious liver disorders are there. Mostly viral infections, common viral infections. All the viral infections like A, then B, then E, then D. These are the common infections, and among all these, this B is very very common, and even the asymptomatic carrier group is there. Now it is called as that term is chronic hepatitis for the carriers of HBsAg who are having no symptoms, but unfortunately they are carriers. So that group is called chronic hepatitis patients. So these chronic hepatitis patients or hepatitis B virus, hepatitis C virus, hepatitis A virus, and so many that infectious diseases are there. In that condition, if the patient is having uh, jaundice, fever, body pain, vomiting, and all, then you have to do the viral markers like blood for HBsAg, then HAV, HBV, HCV, like that you can write, and you will get the first report. If the infection is there, that will be positive, or if it's not there, be negative, and accordingly you can diagnose the patient. Then comes the liver function test. A liver function test means there are a battery of tests in relation to liver function, because liver is a major organ, and as you know, liver is having different functions also. So liver function test means we will be looking into the each and every function. For example, that excretory function. In the level of excretory function, we'll be into the serum bilirubin. Serum bilirubin. So serum bilirubin also again that should be see whether it is direct or indirect. So total serum bilirubin. It is normally it is 0.8 to 1 or 1.2. Then how much the that direct bilirubin is? How much the indirect bilirubin is? So basically, it is an excretory function, excretory fragment of the liver function. So we can say if it is elevated, we can say hyperbilirubinemia. This hyperbilirubinemia can be congenital or non-congenital and occurred. Congenital hyperbilirubinemia is of many types like Gilbert syndrome and so many other diseases are there. But in that condition, in that congenital hyperbilirubinemia, the direct bilirubin will be within normal limit. That means 0.54 milligrams per deciliter below, and the indirect will be more, unconjugated will be more. So that is about the excretory function. Then comes the most important function of the liver is synthesis function. Synthesis function is liver synthesizes the protein. So that among the proteins also the albumin is most important. For example, if a patient comes to you with a white Nile and edema lower limb and with pale that like udara description, then with that yellow eyes, then you have to see the liver function, and you assume that the protein level, the synthesis of protein is disturbed in the liver. Why? Because then if the albumin is low, then there will be edema of the lower limbs. Edema will be there, and the nails will be white, and so many that muscle, the wasting will be there. So synthesis of protein and the prothrombin. Protein means the protein that albumin, globulin, and all these things. Generally, we can say protein synthesis, and that components of proteins will be, or the fragments of proteins will be reported separately. So, protein. Among the protein, albumin is very important. So, we have to supplement the albumin, or we have to give the wheat and all, or milk and all. So many things we have to do. And so anyway, protein. Then prothrombin. That also is a very important that protein which is synthesized by the liver, which helps to uh, help the clotting of the blood. So clotting of the blood. So it is synthesized by the liver only. So prothrombin is very important. Generally, we will write the SPT, prothrombin time. So it is synthesis function. And so liver function means in this way, the different, then transaminase, most important one is transaminase. Transaminase means everybody knows that the previously called SGOT and SGPT, LT and AST. So that ALT is particularly in relation to the that liver, and AST is in relation to other tissues also. But it is an enzyme. Basically, it is an enzyme which is produced as a result of the destruction of the hepatocytes. Hepatic cells will be destroyed, and as a result, the enzyme will be released. So, in all the hepatic damaged condition, or the in the liver cell injury, in all the liver cell injury, we will get an increased that elevated enzymes, and recently we look into the GGT, gamma GT, because it is a sensitive enzyme. It is a sensitive test which clearly denotes the volume of the brain cell damage. Sorry, the liver cell damage. So GGT also is an important test in relation to hepatocellular damage. So you can write SGOT, SGPT, and GGT, gamma GT, gamma glutamine transferase, gamma GT. So these are the three tests that you have to write in the transaminase level. So SGOT, SGPT, if any injury to the liver occurs, the OTPT will be elevated. And if it is in the infectious conditions like hepatitis A, acute hepatitis, then the elevation of that OTPT will be more than 1,000, 2,000, etc. But in alcoholic hepatitis and in some other groups, that the elevation will be that below that 100. So that is the difference. Anyway, GGT also is very important. So then this coagulation factor, that is prothrombin and that PT and INR. Okay, this is about the investigations of the liver disease, and regarding the cancer markers of liver, alpha beta protein. So these are the investigations to be kept in mind in the liver diseases. It is in relation to the Rhetosorodoshirogas. And then comes the one of the most important area of the story, that is cardiovascular system. Cardiovascular system. We are now currently we are also getting so many cardiovascular patients with and some patients will have cardiovascular risk factors only, and somebody is having post myocardial or post coronary of that condition, and we will get coronary artery disease, but not in the acute disease, post myocardial infarction patient. This coronary artery disease having 2-3 presentations like angina, unstable angina, stable angina, and acute myocardial infarction. So, all this category, that except the acute myocardial infarction, all other groups of patients are coming to Ayurveda doctors also for seeking Ayurvedic treatments, drugs and other therapies and so many things. Mm. And so we should know the valuation of the cardiovascular patients also, and we get the patients at risk factor level also, hyperlipidemic patient, that hyperhomocysteine elevated patient means high homocysteine elevated patient, dyslipidemic patients, and all. So we have an idea regarding the evaluation of the patient and what are the biochemical markers which we can use in the cardiovascular disorder. Biochemically, we can utilize biochemical um, means we can utilize the CPK, CK, that what we can say, uh, creatine kinase. Creatine kinase, we can you see, and the creatine kinase is having two, three bands. And in the cardiovascular disorders, we can utilize the creatine CK, MB, creatine kinase, that myocardial band. We can use that the elevation. We have to look into the identification of the myocardial infarction, the stage of the myocardial infarction, the injury of the myocardial infarction. For that, we can utilize the CPKMB and troponin also. Troponin is an acute marker of the that cardiovascular disorder, means cardiovascular breakdown. So that is very useful. Troponin and CPKMB are very useful, and again that um, this one highly sensitive CRP also can be utilized now. And these are about the markers of that biochemical markers. Then hematologically, the acute leukocytosis will be there, and neutrophils will be elevated, and that in that ESR will be elevated. In that, especially in relation to the infective cardiovascular disorders like infective endocarditis, pericarditis, carditis, rheumatic carditis, in all these conditions, the hematological parameters also will be changing. Like the ESR will be increasing to 60 to 100. So that is very important. And this microbiological markers also can be look into, but generally that is coming under infectious diseases. So that as far as thyroid doctors are concerned, that is not that much of utility in the our clinical daily practices. And these serological markers like that which we previously discussed. So these are about the cardiovascular investigations. And in all patients of cardiovascular disorders, you have to look in the certain factors, risk factors. For risk factors, mean there are two types of risk factors in cardiovascular disorders. One is modifiable, and the next one is non-modifiable. Non-modifiable risk factors are age, sex, and family history of the heart attack. That cannot be modified, so it is called a non-modifiable factor. Age also is very important. Gender also is very important, and the that family history of disorder is very important. But modify risk factors we can modify, like hypertension, dyslipidemia, diabetes. These are the and the level of activity or the lifestyle. These are physical activity. These are the that modifiable risk factors. By modifying all these risk factors, we can modify the coronary artery disease also. But while assessment of the modifiable risk factors, we have to look into the lipid level catabolism and the glucose metabolism of the body that we can see. And the common investigations in hematology are CBC and ESR, and estimation of glucose is very important. That is FBS, SpA1C, PPBS, and TGT. See, the estimation of glucose means FPS means fasting blood glucose level, 12 hours fasting, and the values that should be below 110. And if it is up to if it is between 110 and 120, then it will be IGT, and above, then it will be diabetes mellitus, and A1C should be below 6, and that basically we can say that 5.6 is the absolute normalcy, and 5.6 to 6.5 it is that pre-diabetic or IGT, impaired glucose tolerance, and above 6.5 it is diabetes. And PPBS, that it should be below 140, and 1.5 hours that time should be taken after postprandial time. Then GGT means glucose tolerance. That has to be done in a particular population. If you want to do a GGT, now the recent method we can take only two values, and the first value should be 126, and the second value should be 200, and you have to give 75 grams of glucose in 500 ml of water, and you to take two links between the interval. And so this is about the estimation of glucose. And in the estimation of lipids, the total cholesterol should be you look into, triglycerides should be HDL and LDL. These are the common things that we have to look into the estimation of that lipids. And among the total cholesterol, it should be 180, below 190. Triglycerides should be below 150, better 120, below 120. Then HDL should be above 45, and LDL should be below 100. That is the normalcy of the estimation of lipids that can be done in fasting. So while you writing the estimation of these lipids, you can write it as fasting lipid profile. And coming to the kidney function test, renal function test, serum urea, serum creatinine, and serum uric acid are the tests or the components that we are looking into the renal function. And serum urea, that is 20 to 40 is normal, and creatinine 0.7 to 1, or maximum 1.2, and the serum uric acid differs in males and females. Anyway, it should be 6.5 below in females and up to 7 in the male, maximum 7 in the male. And so, serum uric acid is a metabolic is a factor which causes metabolic arthropathy or the crystal arthropathy, and serum urea and creatinine is directly concerned with the kidney diseases. So that is very important. If you suspect some patients with the kidney disease, you have to look into serum urea, creatinine, and uric acid. Together, we will call it as renal function test. And nowadays, what is the problem is that the patients with the type 2 diabetes with a chronicity of more than 20, 30 years will be coming to thyroid doctors for their secondary joint and neurologic problems like periarthritis, that multi-joint pain, like regenerative joint pain, then with the numbness of the lower limbs and burning sensation of the joint pain, means with the neuropathies and peripheral neuropathies and other arthropathies. So, in that group of patients, if the patient is having a long history of more than 10 years or 10 to 15 years, you have to see the renal function test, urea and creatinine. And another test also you have to do, that is called the microalbumin, urine for micro, that is looking into the urine only, urine for microalbumin. Because of that pathological changes happen to the nephrons. What happens is the protein molecules will be trained, and we can see the micromolecules of albumin in the urine. So there is a normal value, and so anyway, you can write urine for microalbumin also. So chronic kidney disease, maybe or nephropathy, means type 2 diabetes related, diabetic nephropathy. And the HB of the patient will be less. And so this is very important. In diabetic patients, more than 10 years or 15 years, you have to look into the renal function. And liver function test already we have discussed everything. So this is about the liver function test. Then another thing is very important thing is the serum electrolytes. Serum electrolytes are very important. So you have to always have a reservation in that area. If somebody else who is having fatigue more than the age of 65, 60, 70 comes to you with the severe fatigue, then naturally you have to see the serum sodium level. These are the electrolytes: serum sodium, potassium chloride, and bicarbonates. And generally, this sodium, potassium chloride, and this is the electrolyte panel. And serum sodium, if it is decreased, it is called hyponatremia, as you know. And this hyponatremia, when it starts gradually, the patient will be presented with fatigue. And if it is advanced, then there will be some neurological symptoms also, like delirium, disorientation, and all. So, the serum sodium, estimation of serum sodium is very important. And especially, you have to ask the patient whether the patient is taking any diuretic medicine to control the hypertension. For example, hydrolazine, that LOSRH hydrolazine, or this Dietone, the diuretic. If these or our other drugs are taking, if any diuretics are taking, then and if the patient is having some other medicines which induce the sodium that channel, means reduce the sodium, then also the patient gets hyponatremia, and as a result of hyponatremia, the patient will get some symptoms that should be very carefully dealt with. So, serum sodium estimation is very important. It should be more than 135. So, if the patient is getting 130 or 128, means the fatigue will be starting. If it is on below 120, means then again major symptoms will be coming. And serum potassium also is very important. And this potassium sodium is having some relation and all. So you go through the textbooks. And anyway, serum sodium, potassium, then chloride and bicarbonate. These are the electrolyte panels, and this should be in the kidney diseases. The electrolytes or bicarbonate and sodium, potassium, and this chloride also will be having having an abnormality. So in renal disease patients, you have to definitely see the serum electrolytes along with that renal function test like urea, creatinine, and uric acid. So this is very mandatory. And coming to the common problem of the present day, vitamin D3. Vitamin D3 estimation is very important. Why? Because number of patients, many number of patients are coming to, many patients are coming to the clinicians with a very vague symptoms of fatigue, back pain, especially the younger age group of 20s and mostly 20 to 30 years of age. They'll be coming to you with vague lower back pain, neck, the cervical pain, and fatigue, and so many other symptoms will be presented with the hair fall, and so many other symptoms will be presented. So, in all that patients, when we look into the vitamin D level, that vitamin D will be D3 will be less. This is called a vitaminosis D3. It is an epidemic disorder. Vitamin D deficiency is an epidemic disorder in Kerala, especially. And so there are number of researches are going on in the etiology behind the phenomena of vitamin D deficiency. Even though we are getting the high sunlight and all, but unfortunately we are losing the vitamin D3. So sunshine vitamin. So that should be estimated, and it should be perfectly speaking, it should be more than 40 or 50. But if it is below 20, means it is a high insufficiency. So that if it is below 20, you have to start some supplementation uh, of vitamin D3. So vitamin D3 estimation is very important. And if the patient is having vitamin D3, his immunity will be going. So as a result, there is having some skin disorders, dryness of the skin, some frequent infections, and so many things happen. So it is very important to see the vitamin D3 level also. So then comes the commonest test that you have to perform in our clinical practice, that is thyroid function test. Thyroid function test, as you know, it is mainly we are doing three T3, thyroxine, T3, T4, and TSH. And TSH is very important because, like vitamin D3, that subclinical hypothyroidism is a common issue in our state, in our country. So, if a patient is, if a young uh, patient comes to you, or any patient comes to you with a severe fatigue and that dyspnea, laziness, and also she has to sleep, then you think about the hypothyroidism or subclinical hypothyroidism, and you must see the TSH level of the patient. So TSH level, there is a protocol, there is an algorithm of the evaluation of thyroid disorder or hypothyroidism or subclinical hypothyroidism. And anyway, the normal hypothyroid means the TSH level should be zero point 0.4 to 4. And if the patient is reported with the 4, then you have to repeat the values every 6 months. Then anyway, it should be kept under the that lower limit. Below 2, you have to keep, otherwise the metabolic activities will be hampered, and as a result, the lipid metabolism and so many other things will be happening. So this thyroid function also is a very common test that we have to be performed in our OPD. And some special tests, CRP, we have already discussed, RF factor we have discussed, ANA we discussed, this serum calcium, phosphorus, and serum magnesium. These are the serum calcium, not phosphate, serum phosphorus. So um, we get a number of osteoarthritis patients, and patients with many that bone and bone mineral disorders. So naturally, we have to look into the level of, or we have to estimate the level of calcium and phosphorus. So calcium and phosphorus should be estimated, which is highly essential for the health of the bone tissues. So if somebody else coming to you with a painful knee or painful back or painful neck for a long period, then not for 1 week or 2 weeks, for a long period, then you have to see the serum calcium level and serum phosphorus level along with the other parameters. And these are about um, the common investigations that we have